All right, good afternoon, everyone. Welcome to Ethics for Lunch. My name is Mark Hughes. I co-chair the Hospital Ethics Committee, and Ethics for Lunch is a co-sponsored by both the Ethics Committee at the hospital and the Government Institute of Bioethics. Great crowd. I think this is our most audience members for this academic year, so that's great. Maybe foreshadowing how the rest of the academic year will go. I'm going to walk you through just some of the CME slides first, and then we'll get to our topic. So to let you know that this is CME accredited, and we will be offering one CME category hour credit. If you want to do that, I'll give you the code in a couple of slides. So we make sure that we have conflicts of interest addressed, and no one today has any conflicts of interest to report. And I do not anticipate we're going to talk about any off-label use of medications, but if that's the case, we will make that clear. We are making Ethics for Lunch available to the whole hospital community, so any staff members at the hospital, but also community members are welcome to come. And our objectives are really just to help improve clinical care at Hopkins, think about the ethical issues that arise in patient care, translate any of the evidence base from the ethics literature into how we think about taking care of patients, fostering better communication among all stakeholders. As I said, no one has any conflicts of interest today. And for today, our topic area is going to be suicidality and autonomous decision-making, especially with regard to life-sustaining treatment. So we're going to talk about the criteria for determining decision-making capacity. When we do have a patient that we are concerned about the risk of suicide, what are our steps to help keep that person safe? What are our staff responsibilities in caring for that patient? And then also, if there are concerns about the patient's capacity to make their own decisions and we're relying on a surrogate decision maker, how do we expect them to be making decisions on behalf of the patient? We use a hypothetical case for Ethics for Lunch. Today's case is just supposed to be representative of the topic area. If there's any chance that we do talk about particular patients, the expectation is that both our panelists and you as audience members will keep that information confidential. And for CME purposes, this is the number to text the code, the 1-844-980-1555. And today's code is 57924. So I'll give you the 2 seconds to note that. And we'll, if you need it later, you can raise your hand and we can come back to it. All right, and you can also go to the CME website, log on, and you can log your time there, but also find out about upcoming events with the CME office. So let me have our panelists introduce themselves. We'll just go down the line. You can say who you are, what you do. Dr. Tripp.
I'm Patrick, but I'm the clinical director of the Department of Psychiatry.
Hi, I'm Karen Ethan. I'm one of the attorneys for the health system, and I oversee risk management and regulatory.
Molly Evans, I am a social worker and inpatient psychiatry at Psychiatry building.
I'm Shannon Barnett. I'm a child psychiatrist and also a RPO.
Hi, Ashley Nealon. I'm a clinical nurse in the surgical ICU and member of the ethics committee.
Great, thank you all. So we'll be hearing from them in reaction to the case, but also welcoming your questions and comments. Well, I'll run through the case and pause periodically just to get our panelists' reactions to it. So this is EW. She is a 45-year-old woman who was admitted to the trauma service after a suicide attempt at home. She was found by her 21-year-old daughter in the bathtub after cutting her wrist and neck. She required massive blood transfusion and emergent tracheostomy as part of the surgical repair of the neck injury. She's now been admitted to the surgical intensive care unit. And after stabilization, she is conscious. She's able to communicate by writing on a pad. Her oxygen requirements are minimal, but she does still need to breathe through the tracheostomy, so she's placed on a tracheostomy collar. A psychiatry consultation is obtained knowing that this was a suicide attempt. The psychiatrist learns that her husband had moved out of the home 1 week ago, actually 1 month ago, to live with his girlfriend, and he legally separated from the patient. He told the patient he is in the process of filing for divorce. The patient started to drink after the breakup and she stopped going to work. This resulted in her being fired from her job 1 week prior to admission. Psychiatry consults learned that 2 weeks prior to admission, the patient had been seen in the emergency department after a fall down the stairs. The psychiatry consultant suspects this may have been a suicide attempt, although the patient does not acknowledge this. Psychiatrist diagnoses the patient with an adjustment disorder with depressed mood. There's no evidence of a psychosis. The consultant feels that it's too early in the process of evaluation to diagnose the patient with major depression. The patient continues to express suicidal ideation. She's felt to be at high risk for suicide and has a one-to-one sitter in her room to monitor how she's doing. Let's pause there and just have our panelists talk about if we have a patient that's come in with a suicide attempt, we think they are still at risk for committing suicide. What are the hospital's responsibility in care of that patient? Anyone that wants to jump in can start.
That's sad. I actually had to turn and ask, is that me? Yeah, so obviously the patient's at high risk for attempting to harm herself again. So, she would be put on suicide precautions and do everything we could to keep her safe as we try to stabilize her medically and psychiatrically. So that would probably involve bedside observer, a sweep of the room of any obviously risky things that she could use to try to hurt herself while she's here with us. It's complicated, especially in a surgical settings and medical settings as well. There's all kinds of equipment there that's very difficult to make it completely safe for patients while still making them functional rooms for patients. That's kind of what the thinking is, trying to take care of a patient in these circumstances.
Ashley, any comments from the figure in the surgical intensive care unit, steps that the nurses would take in concert with the observer?
Yeah, absolutely. I would say, so as a nurse, we receive no training on this in terms of full screening for risk assessment, as well as how to safe our room to the best of our ability. As Dr. mentioned, it's very difficult. We have things that we need in order to keep the patient safe, or obviously greater risk, leads, blood pressure cords. There are also tools that we keep for early safety, and cowers and things like that. And so it makes it a little more challenging to maintain CPO or continuous observer, and do investigation.
Any other thoughts?
I was gonna say, I think, treating her, there's gonna be a constant, kind of tension between her autonomy, and kind of giving her as much freedom as you can, but also restricting ability to harm herself, so that everybody can care of her. Constant kind of.
And I think the only thing that I would add, in addition to the patient safety and ethical considerations, both the Joint Commission, CMS, Maryland Hospital will expect us to do this suicide assessment and to create a safe environment for our patients based on that assessment. So, which is what we normally do, that is legal rules.
just with regard to the risk assessment, there can be, I guess, mild, moderate, and high risk. How do you differentiate the degree of risk and how carefully you need to be with the patient?
Yeah, so that's actually part of the Joint Commission standards. Well, there's a lot that goes into this, and it's probably a talk for a different day. I think some skepticism about how well a human can differentiate between high, medium, and low immediate risk is kind of questionable, to be honest. But with a set of circumstances like this, where she's just attempted suicide, she's still symptomatic. Her risk category would be high. It's pretty easy to stratify her into that category. It gets a little more challenging when we have patients that are designated as moderate risk. There are also, there are patients that are chronically at risk of varying severity as well, which can complicate these assessments. And this is, I think the regulations frankly have gotten ahead of research on this. But with a case like this, I think it's pretty straightforward. It's the patient to do everything we can. And I think it's true for any patient. We're going to try to keep them safe to the best of our ability. As I said earlier, there is this push and pull with patient autonomy as well. We can't put patients into these completely safe rooms and deny them our autonomy. So it's they're with a less obvious case. I think that's where some of that tension comes back into play.
And we'll move on with the case. So over the course of this hospitalization, she develops a fever. She gets a CT scan of her neck and shows that she has an abscess in the neck. She started off intravenous antibiotics for the infection, but then they have the surgery team evaluate her. They determine that the wound requires incision and drainage, and may need to have a tracheostomy, addressed as well. There's revision of that, given where the infection is. For that, she's going to require being placed back on mechanical ventilation in the perioperative period. She needs to go to the OR, need to revive the tracheostomy, potentially be on the ventilator post-op as well. So they do approach the patient for a consent for this surgery. After the risks and the benefits are explained, she declines surgery, says she never wants to be on a ventilator. She says, just let me die. Life is no longer worth living, so just let me go. When they're doing this evaluation, there's no signs that she's got any sort of delirium. She seems to be understanding all the information that's given to her and conveying these wishes to the team. So the surgery team and the psychiatry consultant now are questioning her decision-making capacity, as it seems that the reason for her refusal of the surgery and the ventilator seems to be a manifestation of her suicidality, that she's been expressing this suicidal ideation. She just wants to die, and now they're faced with what do they do in assessing her capacity to both consent or refuse surgery, as well as the life-sustaining treatment. So let's talk about capacity. Which of our panelists wants to handle that? How do we determine if a person has the capacity to make their own decisions?
So there are 4 elements that go into the assessment of a patient's ability to make decisions. And the first, as Mark just mentioned, does the patient understand? Are they able to understand the information that's put in front of them? The second is, the first is, we back up. The first is, can they state a choice? Do they have the ability to say yes or no? The second is, do they understand? The third part is, this is where it starts getting more complicated. Does the patient have an appreciation of their circumstances? Do they understand the implications of a yes or no decision, given all the other variables that are involved? And then the fourth part is, do they have an ability to demonstrate, well, an ability to reason? Can they show you that they've used reason coming to their decisions? Those are the four main components that we think about when we're asked to go see a patient about medical decision-making capacity.
And we do have a policy at the hospital here on assessment of decision-making capacity. One of the appendices in that is a table that's been adapted from Applebaum, who's a forensic psychiatrist that's written a lot about capacity and competence in the literature. And they have this breakdown of questions that you might ask to help determine these four criteria of a patient, and some additional comments about where there might be challenges. For this patient, the challenge is the concern about mental illness. So she's been diagnosed with this adjustment disorder. There's questions of lingering depression, perhaps because of all that she's been going through recently in her life. Haven't made a formal diagnosis of major depression, but certainly her mental health might be a factor in determining her capacity. Can we get other reactions from the panel about how do we assess capacity in that setting?
I think when you have mental illness, it often gets confusing or more difficult, because, mental illness often will get kind of cognitive distortion, that inability to realize that things can get better. So it's very, like, I think in her case, besides kind of the wanting to die, she probably looks like she is capacity for other decisions. I think and I do think if she had said yes, no one would have even questioned her capacity, which is, oh, sorry. So I do think if she said yes, probably no one would have even questioned her capacity, which I think also gets this. We're only questioning her capacity because she's saying no to what I think most people probably think was big game, super high risk procedure. So I think that's, again, I feel like with particularly mental illness where people look like they have capacity, but the question of is the mental illness making people not believe things better? Makes it more.
Yeah, I would say, we talked a lot about that consultation unit, and the your depression really steals that from you, so that you think it won't get better. It impacts how you think of yourself, right? And you're not diagnosed with major depressive disorder, but a lot of similarities in that. One of the things I talk with patients a lot about is that, yes, it seems like it's not going to get better. By the time they get to the inpatient unit, they probably have a lot of evidence that they've tried other patients and it hasn't gotten better, right? So I think that really can complicate things in their perspective. And I think having those conversations with patients and like open it, really hashing out and what that, what those cognitive distortions look like. And I know for this woman in particular, she has a lot of life circumstances for like this. Many aspects of it have fallen apart because of attempt, which makes it that hill will come back up much taller.
Yeah, I think it was a really good point, and she said yes, we wouldn't be having this capacity determination and review. From both a legal perspective, the patients have the right to make their own decisions, and we don't just get to substitute our decision or our thought process for it. And that's why this is such a nuanced evaluation, and so important to kind of have all these different considerations on does mental illness affect capacity in these ways, because we can't just simply say that's the decision I would have made, or that's the decision I think she should have made. And I think with a patient like this, thinking about is there a way to understand or get collateral information about what she might have done before these life circumstances led to this clinical picture that she's coming with. That might be another piece of information that helped inform, because she didn't understand the consequences. But it's so interesting, we often get what we will call, I disagree versus does the person have capacity. There's a disagreement in some decisions that the person has.
I would agree with everyone. We often get to these conversations when we don't like what the position is. And I think that it's tricky because if you have the capacity to explain, you would have reasonably made this decision prior. I would have not wanted mechanical ventilation 2 months ago. I also continue to not want it now. There is a patient autonomy there that it should be respected. I wonder if there's anything related to the degree of what's manifested. So the recent suicide attempt that it automatically changes our assessment of capacity.
I will say that she has no advance directive. There have been no prior statements on her part about ventilators or, surgeries or anything. So this is all new in terms of her making a decision now. So we can't rely on maybe past preferences that she's previously expressed. And there's still going to be this question of the cognitive distortion that's coming from her mental illness. How is that impacting her ability to make this decision? She's saying, just let me die. And that's the motivation for refusing the surgery. Can I leave it as an open-ended question, or does anybody in the audience want to suggest how would we respond to this? You have a hand there. We'll wait for the microphone.
Hi there. I might have a different perspective because I'm an emergency psychiatrist. So, but looking at a case like this, when you look at not even does she have mental illness because they're calling it an adjustment disorder, which is in the DSM, but it's meeting the criteria for a major depressive disorder. It sounds like not yet, but her suicidality, being active, saying she wants to die, could impact her decision-making capacity. So I would say if in the moment, if what we're saying is that she didn't have a previous history of not wanting to be on ventilation, having a DNR order, or having a different, a difference in what her desires would be. If you don't have them, you're only met with what you're seeing now. Her suicidality being active could impact her ability to appreciate all the consequences of her decision.
So part of that third part of the decision-making capacity assessment is the circumstances. I think this is part of what we're talking about right now. She's not expressed wishes about ventilation before, and I can't imagine that the topic of draining an abscess or not had come up. She's said things that were wildly pro-bacteria in the past. I don't think she would have said something like that. And everything is housed within that context of suicide. I want to die. So and this is where I think there's a trap here. We can think of suicide as categorical. Well, suicidal, therefore everything she says is wrong. We can't trust it. But I don't think we can speak in absolutes about that. Just as an absurd example, so let's say the surgical consultant walked in and dropped a pair of scissors on the floor. She picked them up. Would we stop her from killing herself? Probably. Not seeing any heads nod, which is a little alarming. Cynthia in the back is probably nodding. Yeah, I mean, come on, that's our job, right? We've already laid that out. We have responsibilities for her. We can't let her kill herself with a pair of scissors. I think there's we can go to the next step and say, well, we can't let her die of an infection in our hospital right in front of her either. But there are times when things get murkier. If she had a terminal condition, for example, and was talking, using that same kind of language, descriptive language of suicide, I can't go on with this anymore. I'd just rather be dead. That's where things get really complicated. I'm not doing this to make this a more complicated conversation, but I I do worry a little bit about talking about suicide in absolutes, the categorical yes or no, and that was the only factor that goes into decisions about her ability to make decisions in this setting.
The only thing I would add is I think that's a really important point that, capacity can be along a spectrum, and it can be for certain things or at certain periods of time. It doesn't have to be like, yes, they have capacity in all respects, or no, they don't have capacity. That is widely accepted in the legal and ethical framework that capacity can be selected.
Do you think that translates to then, so she was placed on IV antibiotics, could she make a decision, yes or no, for the antibiotics? Is that within her purview of capacity? Is that another determination, not just a surgical procedure or ventilator, but actual just medication she's using?
Absolutely.
I want to say one other thing, just kind of going back to the ER, as a psychiatrist, I learned, to decide whether or not to be met involuntary commitment criteria, which is a key thing for some or others, without ever the idea of capacity being in that. So psychiatrists, when we're deciding whether to hospitalize somebody against their will, we're never thinking about capacity. So this is different because the issue right now isn't whether she gets voluntarily hospitalized. But we have a lot of things in place for mental health, but we're not on a medical floor, that kind of legal protections for the patient, but also the ability to treat suicidal behavior that also I think is important.
So even though she's not on a psychiatry unit, she's on a surgical floor or surgical intensive care unit. Is that counting as involuntary hospitalization? Because she's expressing a risk of harm to herself.
All right, I'll speak in absolutes. Yes. This is a patient where in real time, if she said, well, I'd just like to go home now. Thanks everybody for your hard work, but I'm gonna head on home. We would not let her go. And again, it's because of this context of her expressing her intention to die. She's going to kill herself. Actively suicidal patient. But Chan's point is a really good one too. There are times when these distinctions between psychiatry and the medical floors are really distinctions without much of a difference. So in a sense, she's not technically on a psychiatric hold, but we would probably say she doesn't have the capacity to leave the hospital against medical advice in these circumstances.
Take your question. Here's the microphone.
I just feel like I'm talking about everything as except the one thing that drove her to the suicide. She lost everything. She lost her job. She lost her husband. And I think that's a trigger, and we are asking her whether you want surgery or not. We're not asking her why she wants to die. I feel like it will start like, why do you want to die? And we will know where she is at. So before we talk about capacity, let's know how she got here.
Molly, do you want to react to that? As a social worker to really get that psychosocial history?
Yeah, no, just not in my head. Yeah, I totally agree with you. I think that's a huge piece of it. And I think that hand in hand with these conversations about capacity, that we do need to be talking to her about, how did you get here and how do we move forward, right? Like everything. I think depending on where that conversation goes, right? Like she has lost a lot, and that is a very real concern, right? Like that piece of it is not a delusion that she's having. It's not a cognitive distortion, right? There's a lot of challenges that she faces when she gets home, but I think talking through, what does that look like, and working to instill hope that things can get better, right? Even with all of those factors considered, I think is a really important part of it. That's about that. Let's do a different angle. I think but absolutely valid. These are also the time limited decisions. you have lost your job and your family, and I can't get those back to you before you're going to die of sepsis. And so these are, clinicians are being asked to make decisions outside of the ability to create a therapeutic relationship. Challenge.
It would certainly seem, we have another comment.
Thanks, I have a question. Given that I think thinking about the third level criteria with respect to this patient about reasoning, and I think asking follow-up questions about why she wants to die might be really important if there's time. Because if the cognitive distortions associated with compromised mental health make it the case that she lacks the ability to imagine a livable future for herself, then she can't do that reasoning well. Because one has to like imagine what it might be like. She's optioning or should be, it's just like a general feature. So I suppose I think of determining whether she lacks that ability at the moment would be really important to assess.
So both the appreciation of the current circumstance, all that she's been going through, but also her ability to reason through seeing herself in the future is your point of, when you have the hopelessness and helplessness of the adjustment disorder and, this recent suicide attempt, somebody has to create that hope for her to say, you could have a future self, even with all these losses.
And if she lacks that, she doesn't have the
And then the lack of hope, inability to see yourself in the future might speak to a lack of reasoning ability to weigh those risks and benefits. Other comment?
So obviously suicide is a huge and irrevocable decision, and so our standard of evidence for capacity has to go up. But it's suicidality has all these worrying correlations, of course. I'm very skeptical now of this right to make a bad decision and what it actually means if we're like, oh, this is just hospitalization. Even if I agree that this patient is probably trapped in the moment, and this is probably not a case to argue that that's the best option. I'm just wondering when we even allow choices to be made. Does that make sense?
Barb?
All right, I got that one. That's yeah, you're right, and this is a difficult case to stand on that ground and say people have the right to make a bad choice. This one's a tough one for that, and yeah, nearly impossible. That being said, there are circumstances where we're asked to assess a patient's capacity, and they fulfill all four of those criteria. And they still make a decision that we think, oh, no, you shouldn't do that. That's definitely not the decision I would make. And that's the trap, is that we're substituting our judgment for theirs. And we're discounting their autonomy. We're looking past the fact that this is another human. They have values, they have ideas that we're not privy to sometimes. So again, if they hit all four of those criteria, there are times where, unfortunately, we're in that bind, and we say, well, we have to step back now. This is the bright red line we can't cross, because this patient has the ability to make this decision, even though we don't agree with it.
Sure. My word here is that could be the moment that they choose to grab the scissors.
Right. Well, you mean this patient?
I would just want to add that I think when we talk about what is going to be the outcome quickly, this is something if you don't intubate immediately, and she's gonna, it's gonna be life-threatening immediately, then your decision about her questioning if her suicidality, what it is, what's the meaning, what's the hope, you really don't have time to do that. But as opposed to a decision that might be bad, if you have time, that there's not gonna be a horrible outcome. So I think if the question were, if she, based off the law we know, does not want to do this, and she just said, I want to die, and she's actively suicidal, but if she doesn't get intubated immediately, she's going to pass away, would the decision be different as far as the dilemma about giving her autonomy or questioning if she should have it? If it was that she doesn't get intubated, she dies in 30 minutes, would that change the decision making of the people evaluating?
Yes.
Just say, hearing that question, makes me very glad to be on the patient side of things, that we have a lot of more time. So anyways, just to put that out there, I'm having a reaction as you're talking about making these decisions quickly.
Yeah, and Cynthia, you're right, that in the emergency department, it's a different set of factors, and the time one can be critical. And there are times where it's an emergency and a patient's not even able to state a choice. Then it's the physicians at that point can say, well, this is an emergency, and we have to act now, and they do act. That's the standard. They have to document their reasoning for doing that in the moment. But that's the lawyer sitting next to me. This is the accepted standard for emergency care. If some contingencies like that were to crop up.
What they say the choice in, they say the choice, but it's still in that situation. That's where I think.
Look, it's, if she's a document says do not intubate,
Well,
that's a different. That's different.
Right, so we will say that the team came up to the determination after having these thoughtful conversations with her that she lacked decision-making capacity. So then the next question is going to be who would be making decisions for her and surrogate decision-making. Harry, do you want to walk through our legal hierarchy for determining the decision-maker for patients?
Absolutely. So under Maryland law, they lay out who makes a decision once the patient is not able to make their own decision. One option is the patient already has an advance directive and they've named a particular healthcare agent. In the absence of that, we use the surrogate hierarchy, which starts with a spouse, starts with a legal guardian, moves to a spouse or a domestic partner. In this circumstance, they've indicated that she's legally separated, not divorced, so technically the husband is still her spouse. But in the law in Maryland, the legal separation removes the spouse from the hierarchy. And so you move down to the adult child. And then as you can see in our policy and in the statute, if we go further, there wasn't an adult child. So we are at the point where the 21-year-old daughter becomes the decision maker for this patient because the husband is legally separated at this point in time.
Let me throw the twist in and see if the audience wants to react to this or our panel. What if the husband had not filed for legal separation? He was still married and had already expressed his desire to leave the marriage. Legally, he would still count as the highest on the list in surrogacy. Is he the appropriate decision maker, knowing that this marriage is in disrepair? How would people handle that situation?
They're on the chart, there's a husband who still follow. It's usually more family members that step in.
So the suggestion from the audience is because he is highest on the list legally, you would still contact the husband to find out if he wants to serve as decision maker or ask him to be the decision.
I think that's when it gets really great for us. Like nursing at the bedside a lot for these consents and we're part of these conversations a lot and they are called, but it sounds like she has a daughter who is very involved. Hopefully the daughter steps in and those conversations are had that the husband says, I don't want to be a part of this. We are not together and the daughter should, but we've been in very complicated situations like this.
Reactions from the panel?
From a legal perspective, I think that's exactly right. So technically, this is the decision maker, so that first phone call to the husband is the right kind of legal answer, but expressing, we understand that you left the home, that the marriage is no longer intact. You should include your daughter or include her daughter in the conversation. There's nothing that precludes you from including the daughter in the conversation, even if is the legal decision maker. That person can still be part of that discussion. And then certainly if the decision maker, husband is making a decision that you don't agree with, that's the point where we can step in and say, this decision maker is now not acting in their best interest. So I don't at all discount how difficult these conversations are, but involving other family members is exactly what I recommend.
When I think that that's all, assuming that we can get a little bit in the first place, I think about how many times we might know that XYZ family members exist, but tracking them down and getting them to call you back and have a conversation with you is a whole nother ballgame. So I know that can often complicate things. You also touched on again the concept of limited capacity. I wonder, like, if this patient could express, I absolutely do not want this person to make my decisions for me. I want this person to. I think that's the other.
I'm looking to Carrie. There is a distinction between medical decision-making capacity and testamentary. I mean, putting my hand lower because it's a lower standard. This is a tough one. I don't know what the rules are in this, but this isn't just a human who's deciding to break a relationship with another human. One could argue they had a role in why she's in the hospital to begin with, and her thoughts of wanting to kill herself. This is very emotion-laden stuff, and for him to be in that decision-making role, I think it would take a lot of thought on everybody's part. And should he be the sole decision maker? What are the, as mentioned before, what kind of decisions is he making? Is he really working in her best habits? Well, there's a lot. That's a tough one.
I just wanted to ask, if the person loses capacity just by making a decision that we don't agree with, because one of the panelists said that if the husband makes a decision that we don't agree with, then we question it. So does this person's capacity get questioned just by making a decision that we don't think is right?
So for the surrogate, are we making a determination of their capacity to make a decision if we think they're making a bad decision or a decision that's not in the patient's best interest?
I think we start with the assumption that they have capacity. It's not until something comes along, we would be given a moment of pause to think twice about it. I think that may be wrong. I think that's the assumption, is that this is not our patient. First of all, we're not actually formally assessing their capacity to make decisions. But if there's something that seems anomalous, something odd about it, I think that's when we start thinking, well, what's going on here? We need to be that's where we need more information, honestly.
Yeah, and I think that threshold for substitute decision-making is lower when you're dealing with a surrogate, right? You don't have to kind of, the concept of autonomy doesn't exist with the surrogate. The surrogate's supposed to be acting in the patient's best interest. So, they start to make decisions that we question and don't think are in the patient's best interest. It's appropriate to question their ability.
Going back to that earlier, this is the middle of this was an involuntary admission decision. We're not going to be looking for surrogate decision. We take over in children, DSS takes over, or legal takes over, right? So why are we looking for a surrogate decision maker here? We're just looking for someone to agree with our recommendation that we should keep our life, right? So do we really need a surrogate decision maker?
Yes, because this is not kind of your legal involuntary psychiatric admission process. And then even in that process, we still kind of can't do everything, medicate, perform treatment without the patient's consent or another decision maker's consent or the court's consent to do that. So the threshold for involuntary admission doesn't then kind of negate consenting for treatment once you're involuntarily committed.
But it may also be the case that if you talk to the surrogate and you learn something about the patient's history that suggests that maybe her best interest would be served by refusing the ventilator, refusing the surgery, maybe they've had past conversations, and you are convinced that the surrogate is making decisions that are in the patient's mind, substituting their judgment for the patient, then you might go along with the decision that you think is not medically best interest, but best interest for the person, knowing, their whole history.
So two thoughts. One is, to Ashley's point about, decisions being context specific. So the question about capacity in terms of appointing another healthcare agent is a different question than deciding about treatment. So it's quite reasonable that the person could have capacity to choose a surrogate and not be able to make treatment decisions. The second one is in this idea of trying to, we've talked a lot about autonomy. And it seems like there could also be an argument that is made that in these kinds of complex situations, we might prioritize sustaining life for the potential to restore this person to full capacity versus acting in an emergent way on their expressed choices. So that's a different kind of argument than autonomy, which is about, in the context of confusion and uncertainty, that when there is a life-threatening situation, that we might act in the short term for the purpose of restoring capacity versus gating that person's decision.
So buying more time by pursuing the treatment and then seeing if she can get over her adjustment disorder, decide if she needs, further psychiatric treatment to then regain her capacity.
I would agree that someone can have an ability to appoint a healthcare agent. That capacity is possible without the capacity of understanding medical decision making. And I think many of you are probably familiar with our policy that allows someone to create an oral advance directive so that you could say at the time, I want my daughter to be the decision maker, needs to be witnessed by someone else, that can be documented in the record of the oral advance directive, and then the daughter becomes the healthcare agent as well as the surrogate on this list.
So by virtue of the fact that they had a legal separation, they did not contact the husband, they decided to go, only has the one daughter, no other children, and went to her daughter as the surrogate decision maker. She's been visiting the patient. The daughter says, well, enough is enough. My mother's been through so much. If she wants to die, let her die. If she does not want surgery, I will not consent to it. So now, any thoughts from our audience of how to handle this situation? We've got the patient saying, I don't want surgery. The daughter saying, just go along with my mother's decision.
That's the daughter's capacity.
The comment was, assess the daughter's capacity.
I have a kind of buying more time question. I'll give you a little context first. I'm here as a chaplain intern, but the rest of my life I'm a rabbi patient. And I wonder how you would weight the perspective of a patient's religious leader, especially in this context. In my own tradition, as many of you know, we must do everything we can to prolong life, but we may not do anything that prolongs death. And the question of anguish comes up, but that's the story. So, she were my principal, and I recalled, I would try to convince both patient and the surrogate, to go along with this, but I would commit to not giving her the same advice if she were to make an anguish that we have to take into account. So how would you weigh religious beliefs? I'm not asking as a chaplain, I'm asking as someone who found my calling.
mean, I think some of it goes back to the issue of time in these decisions, right? I think if there's time and if you have a relationship with chaplain or rabbi, absolutely, I think, you know, my initial reaction on reading this second part of the case study is, oh my gosh, I would like to have a sit-down family meeting with the whole team, with the patient, with the daughter, and certainly if there was a relationship with a religious leader, would welcome that person to join as a support.
I would say, you know, having a religious leader, especially if it's somebody that was involved in a religious community, speak to that person's kind of chronic desires. Which is, I think, one of the things that we're trying to say, separate is this just an in the moment decision, but she would, both her past and likely a future self make a different decision than her current, than what she's making currently. And I do think, particularly in somebody who's involved in a community that actually can help talk about her, particularly her past or future selves, that they would.
I think these are all great points. It's also, it's a moment of opportunity for her, you know, the person affiliated with her religion as well, to be a support to her. But also, I think for the clinical team, it's helpful as part of these discussions to find out more about what does this mean for a person who identifies solely with their marriage. The loss of the marriage is the biggest thing in the world. It's a life-ending catastrophe. That can be the work of a religious support, but also the clinical team as well, and in working on things like context. This all happened, it sounds like, within the period of a month. So these things are all very raw, or how long they were married, but it's a lot to unpack, it's a lot to work on. And I think the kind of bias that was expressed earlier is it's a lot easier to do that with a patient who's still alive than an autonomous dead patient. I'm not trying to be a smart aleck about it. It's that is kind of the bias that we operate with. We need to do everything we can to keep them alive, to try to help them and stabilize them. There are times, to your brought up a point before about the second suicide attempt. There are patients that are chronically emotionally unstable, chronically suicidal, going back to, childhood, adolescence. It didn't sound like this was the case for this person. That can sometimes lead to a different discussion about what we do in some of these circumstances. So it's a lot, but the short version is, we definitely want a religious figure in our life to be part of these discussions.
Both to support the daughter, but also to help the patient cope with the anguish that she's experiencing from these losses. So any means we can provide support to the patient to help her see a different future be the goal. Any other comments about the criteria that the surrogate decision maker should use? Or commented that it should be a substituted judgment on behalf of the patient. Information that is making a current decision. How do we explore whether the patient might have made a different decision years earlier, which might be a better reflection of her autonomous preferences? Any thoughts there? Find another one.
I do think talking with her about, or with particularly her daughter, and giving a lot of psycho ed on adjustment disorders. Definitely, I wouldn't say as a psychiatrist that she has an untreatable mental illness. We have a pretty high expectation that adjustment disorder will get better. I do agree that
This was somebody that was chronically dysphoric and suicidal and distressed for years, but that might be different. I do think what I was saying, but, just with her daughter to help her and to help her also understand, like, making that best interest, not just for her mom today, but for her mom in the future.
Let me ask this, go ahead.
Oh, I was just gonna say, I'm just thinking about the fact that the daughter will be 21, right? So I'm also thinking, right, like, how realistic is it that they've had conversations about end of life care and what mom does and doesn't want? So it is interesting, yes, the daughter is an adult and she, on the hierarchy, right, like she's, you know, right after the spouse, but it is an interesting kind of dynamic that there are probably other people on that surrogate decision list who might have had different discussions with the patient, so.
It argues that you might want to ask her parents or siblings or others in her life to come and help the daughter with decisions.
Yeah, I mean, it's ultimately the daughter is the decision maker legally, but yeah, I mean, I guess I would want to see if there could be other family members that we get involved in the discussion. Because sometimes, you know, that can be more complicated when people have different opinions, but I also wonder in this case if it might be helpful.
To that point too, that there are times that we get so fixated on this legal decision compared to, you know, things like consulting with the later, or maybe another family running. Friends, everyone is, if it's up to the patient and their decision maker, welcome to join the conversation.
So this question, Carrie, can a surrogate decision maker make a decision? This patient does not have a terminal illness or end-stage condition. She's not in persistent vegetative state. Can a surrogate decide against life-sustaining treatment if the team thinks that's in the patient's best interest?
So the legal answer in Maryland is no. Right, the surrogate decision maker is the decision maker, except when it comes to end of life. And unless you meet these criteria. This is the chart that's on the Attorney General's website. It's also linked in our policy, and we use it a lot, but I think we're down in the, you know, would the withholding or withdrawal of treatment reach the standard of care? And when you have a clinical team saying it would reach the standard of care, then the surrogate daughter can no longer make that decision. That kind of gives you a now what, which I think is where the discussion with the family, adding family members, adding faith leaders, explaining to the daughter that you can't make this decision because of these rules and because it's not in her best interest, and because it's not the standard of care. Hopefully you get to a place where the daughter is making the decision that's within the standard of care. But if not, then I think our choices are referrals to adult protective services, seeking legal guardianship from someone else. So avenues that are time intensive, resource intensive for all of you as clinical folks, but the necessary step if the daughter is still refusing to give consent.
Comment in the back. Wait for the microphone.
If she can't refuse the surgery, why did we bother asking her?
So we had to ask her because you need a decision maker, right? If the patient is not consenting, doesn't have capacity, right, then you need someone else to make the decision. So this was the next person that we had to ask for the decision. We can't just substitute what we think we're supposed to be doing and then just do it. We need to get some legal authority, either by the decision maker or a court or adult protective services. And that's why it's, I guess it feels futile, but we have to have a decision maker.
It seems like a place where we get a little tangled up. Because we have the assumption that the surrogate is authorized to make all sorts of decisions. And so the response that should happen when the person that we've identified as the surrogate makes a decision that is basically outside the ethically permissible and legally permissible range of options, then the response should be that decision, unfortunately, falls outside of the scope of your authority. But I feel like a lot of times the clinical team doesn't feel confident in making those boundaries clear. And so then what happens is we end up with a whole series of conflicts that get a lot of energy associated with them. So I'm just wondering, are there any suggestions that you have about how we might avoid that situation?
So I think from a legal perspective, I would see the conversation with the daughter being determined that this is life-saving treatment. We've determined this is what your mother needs. We need you as the decision maker to consent to it. And if you're not willing to, we may need to find another decision maker. Like that could be the presentation, as opposed to we need you to consent and say yes or no, right? Being clear that no in life-saving treatment, if not terminal, they are not end stage, it's not within the standard of care, no is not an option. So I think to your question in the back, if we asked her because we need a decision maker, but we can guide her to what her decision options are.
And to your point, very important for the team to know have that information ahead of time before we start having conversations and making it very murky.
Question. Would an advance directive essentially did not want that information impact our ability to define it?
You have the other chart.
There are four algorithms. I did not include that in the PowerPoint, but there is one where there is an advanced directive and the surrogate is making a decision based on the advanced directive. So we have patient preferences, therefore the surrogate is really making a decision that the patient would have made themselves.
So there's still the discussion about terminal, end stage, or persistent vegetative state, and there's still the standard of care analysis, even with a healthcare agent. It feels like the healthcare agent would have had that discussion, and so maybe the standard of care discussion happens a little bit differently, but there's still that analysis, even with the healthcare agent.
And there is a provision in the Healthcare Decisions Act in Maryland that says the physician could challenge it, even if it seems like a decision that the surrogate could make that would be within the standard of care. If they disagree with it, they think it's ethically impermissible, they can challenge it in court.
Yes.
All right, so we've made the case even more complicated for you all. Any final comments or questions?
What in this process would you consider getting an important one?
So typically, that's kind of the last resort, right? Seeking a guardian that then removes the family member from being the decision maker, or removes the patient from being the decision maker is the last resort. But as I think all of you know, we do that a lot, and it's emergency guardianships, temporary guardianships, but it usually is the last resort.
And one of the resources here at the hospital would be the ethics committee. So, the ethics consult service could help in really trying to understand all the dynamics of the situation to help reach a decision before we have to go to the court and determine what is ethically permissible within the standard of care. All right, well, we'll end it there. Thank you all for your participation. We hope to see you next month at that